I'm Pablo Andújar, a senior rheumatology resident at Dr. Peset Hospital, and I've been assigned to talk to you about how we carry out the initial diagnosis and follow-up of patients with systemic sclerosis. All right, let's start by considering the initial situation, shall we? The patient arrives at our clinic. Ideally, our departments would be equipped with... It's important, but it can't just be lying around. All right. If we had specialized clinics for Raynaud's phenomenon, it would allow us to identify a greater number of patients who might otherwise go unnoticed. So how are these patients going to present? Well, the most common form of presentation, the most common reason for referral to our clinic, will be the presence of Raynaud's phenomenon, which is usually the initial manifestation of the disease in most patients and is present in practically all of them. We can investigate the symptom either by showing the patient photographs that we can find on the internet to see if they recognize any of the phases of the phenomenon, or if we're lucky, by having them show us an image from a past episode they may have experienced. And what steps should we take next? Well, it's not enough to simply confirm the diagnosis of Raynaud and stick to the classic protocol. We must also carry out a thorough and targeted medical history to look for environmental and lifestyle factors that may also influence the onset of this phenomenon. We will complete that medical history with a targeted physical examination based on the symptoms the patient describes, and it will be important during this examination to always assess the vascular aspect, check pulses, evaluate blood pressure differences between both arms, and also look for other signs that may indicate evidence of an underlying systemic sclerosis. And we will always complete this initial assessment with a capillaroscopy and an autoantibody study, which our colleagues will discuss later. With all these diagnostic elements, we may find ourselves facing one of two situations: either an established diagnosis of systemic sclerosis or a diagnosis of systemic sclerosis in a very early stage, depending on the criteria we use. And from here, we need to continue investigating during the patient examination to build a picture of the patient profile we are dealing with. But it's also possible that the patient comes to our clinic for other reasons. The patient may be referred to us due to the appearance of skin lesions in the form of induration or skin thickening, and we are asked to assess whether there might be an underlying systemic sclerosis. Others will come to us with ischemic lesions on the fingers or other equal areas. And finally, some may come from multidisciplinary consultations, from radiology or cardiology, to evaluate a radiological finding or the presence of pulmonary hypertension, which may be based on an underlying systemic sclerosis. It is important that when patients with skin involvement are referred to us, we always rule out the possibility of a scleroderma-like syndrome. For a quick assessment, we can simplify it by asking or observing whether the involvement includes the fingers or not, since if the fingers are spared, we can rule out systemic sclerosis and should look for other diagnoses. Many of these scleroderma-like syndromes will not present Raynaud's phenomenon, which can be a useful clue, and in many cases we will need a biopsy to reach a definitive diagnosis. And just as we do with patients who have Raynaud's phenomenon, we will carry out a targeted medical history in this group of patients, always starting with a question about Raynaud's, looking for other symptoms during the medical history, and we will complete a physical examination searching for signs or clues that may suggest underlying sclerosis. And like we do with the other group, we will always finish with a capillaroscopy and an autoantibody study. And as Adrian mentioned, it is always useful, even though the classification criteria are not diagnostic criteria for the disease. But if we are not very experienced with this type of pathology, having them on hand and consulting them can be helpful to determine whether we might be dealing with a case of systemic sclerosis. What should we do next? Well, once we have established the diagnosis of sclerosis, we need to define the patient's clinical phenotype to understand what we are dealing with. And to define that clinical phenotype, we need to base it on skin involvement, not only its extent, but also its progression. On the autoantibody profile, the duration of the disease, and other nuances that allow us to identify special subtypes of patients who require particular considerations, which we will discuss later. Regarding skin involvement, I won't go back over the classic types by Leroy and Metzger that Adrian has already mentioned, but I will say that a visual assessment alone is not enough. We need to quantify it. And we'll do this using the Rodnan skin score, which Adrian will explain how to perform later on. And we should not only assess the extent of skin involvement, but also how this involvement progresses over time. Several progression patterns have been described. We have patients who initially worsen, and around the 3-year mark, the skin involvement tends to stabilize or even regress. Then there's an intermediate group that tends to worsen more abruptly and intensely at first, but also improves within the first 5 years. In this subgroup, we will find patients with RNA polymerase III, and then we have a group of patients who continue to progress from the very beginning. We also need to be aware that it is important to note that certain patients may experience progression or skin involvement at a later stage in the future. And in this U-star cohort, it was observed that around 20% of those patients in the cohort would develop skin involvement beyond 5 years, and 3 patterns were defined. Patients who initially worsen, then improve within the first 5 years, and after 5 years experience skin worsening again. Patients who remain stable during the first 5 years and then begin to show skin progression, and patients who experience continuous progression from the onset. And why is this important? Because that skin progression can also be associated with progression or involvement of internal organs, so we must stay alert, especially regarding the interstitium. Regarding antibodies, I won't go into detail, but as Adrian mentioned, we need to dispel the idea that certain antibodies are always associated with a specific phenotype. That's not the case, and we need to stay vigilant. And going back to those curves we saw earlier, we can see that all those with late skin progression were anti-topoisomerase positive, and none of them were anti-RNA polymerase III, which tend to behave in a more benign way without late skin involvement. And it's also possible that, over the course of the disease, other phenomena may occur, such as patients developing more than one specific autoantibody, or losing or gaining antibodies as the disease progresses. And what significance does this have? Well, with that loss or gain of antibodies, the patient's clinical phenotype can change, as well as their risk, or the type of involvement that the patient may develop. This raises the question of whether it would be necessary to test a patient with systemic sclerosis for antibodies. Routinely, it typically wouldn't be necessary, but if we observe that the phenotype changes over time or signs appear that don't match the patient's previous presentation, then we should indeed request them to see if any change has occurred in the patient's condition in this regard. It's something that is rare, but it has been documented. Regarding antibodies, I won't go into all of them. I'll just focus on anti-RNA polymerase III, which have some particular characteristics. These patients usually experience rapid and intense initial skin progression and often present with tendon friction rubs. They may present with renal crisis and antral vascular ectasia, and they often have synchronous cancer, which can appear from 2 years before to up to 5 years after diagnosis, most commonly breast cancer. EULAR proposes some cancer screening strategies for these patients, especially during that window period when the risk is highest or when there is a greater chance of it appearing. Regarding the duration of the disease, we are not going to manage a patient who has just presented with symptoms the same way, especially if it's a diffuse form of the disease, as we would a patient who has had the disease for years, even if it's also diffuse, who has been going around and now comes to our clinic. We will perform a screening, but afterward we will manage or be more cautious with the patient who has just presented with symptoms, because that is the patient who is at higher risk of progressing and developing complications. We have to take other factors into account, such as age. Does age matter? Yes, it does matter. Why? Because patients who present at an older age tend to have faster progression and more severe involvement simply due to the fact that they are older and already carry a higher burden of comorbidities. Regarding the initial assessment, in addition to what I mentioned earlier about capillaroscopy and autoantibody testing, we should also perform blood work, which should always include muscle enzymes and a baseline NT-proBNP, among other tests. If the patient presents with active arthritis symptoms, we should request antibodies such as rheumatoid factor and anti-citrullineated protein antibodies to rule out an overlap with rheumatoid arthritis. If there are ischemic lesions, we should request antiphospholipid antibodies. If we suspect another autoimmune comorbidity, we will request the antibodies we deem appropriate. As a baseline, we will request from all patients a baseline high-resolution chest CT scan, HRCT, which will allow us to assess whether there is interstitial lung involvement, its pattern and its extent, a spirometry with DLCO, an echocardiogram, an electrocardiogram, and a gastrointestinal study which we can perform using a barium esophago-gastroduodenal transit or with radioisotopes, which are beginning to be used in some centers. We will screen for pulmonary hypertension in all patients, which Patricia will discuss with us later. And we must always be cautious when attributing causality. That is, we might fall into the mistake of thinking that since we have a patient with systemic sclerosis who can present with manifestations at multiple levels, anything new that appears can be attributed to the disease. We have to keep in mind that those findings that may appear could be related to medications, infections, so we must not fall into that trap. It also doesn't hurt to request a hand X-ray, which allows us to assess for acroosteolysis or calcinosis. If the patient reports symptoms of dryness, then a Schirmer's test, basal salivary secretion, and always examine the patient's mouth. Then, in particular cases involving specific organ involvement, we will carry out a more targeted study of those organs. In cases with a risk of neoplasia, such as patients with anti-RNA polymerase III antibodies, late disease onset, atypical or aggressive early onset scleroderma, or constitutional syndrome, a battery of tests should be performed to rule out an underlying neoplasm. And regarding follow-up, we need to distinguish between two main groups. Those patients who have diffuse or limited disease but are positive for anti-topoisomerase antibodies and have had the disease for less than 3 years, we will monitor them very closely because they are at higher risk of developing complications and progressing. These patients will undergo a clinical and laboratory evaluation every 3 months, including the Rodnan skin score. For those with RNA polymerase III antibodies, we will also recommend home blood pressure monitoring to stay alert for a possible renal crisis. Pulmonary function test with DLCO every 6 months. If we observe any abnormalities in this test or the patient presents new symptoms such as dyspnea, then we will repeat the HRCT, Doppler echocardiogram, and pulmonary hypertension screening annually, along with other studies depending on the findings. And starting from the 3rd year, we can begin to relax a bit more and space out the tests with clinical and laboratory evaluations every 6 months and the rest of the tests at least once a year or more, depending somewhat on the patient's profile. And in the neoplasia segment, I'm not going to talk again about those screening criteria proposed by EULAR for the study of RNA polymerase A3 or also a possible Barrett's esophagus or other complications that may arise. And we must also not forget about comorbidities, meaning that we are doctors and we also have the ability to screen the patient's blood pressure status, cholesterol levels, and to carry out an approach, a treatment. In this regard, since the patient already has macrovascular involvement due to their disease, an involvement that is accelerated by the disease itself, being able to control what is within our reach would be good clinical practice.